But if in thinking, moving from that, what is really essential to what are the steps for leading change, I find it helpful to go back to one of my favorite authors around change management, John Kotter, who wrote a book several years ago now called Leading Change. And he was talking about big change, not necessarily quality improvement kind of change in a practice, but in thinking about this, I thought it was a really helpful framework, granted with some accommodation, some maybe editing of some of these comments, but whether you're talking about leading a big cultural change, a social movement, a political change, or I would suggest quality improvement kind of change, I think that these steps can be very helpful. So I'm going to just use this framework to walk through. So one, establish a sense of urgency. In medical practice, healthcare today, I would suggest that the survivability of practice is a strong element of that sense of urgency, right? So we don't have to go too far for practices to understand that they absolutely have to engage in a process of quality improvement or changing who they are, right, to survive in today's environment. Whether those are changing and rising, truthfully, expectations for performance, for accountability, for outcomes, particularly in the context of ongoing value-based payment reform, and now the newest kid on the block, right, our friends macro-MIPS, the federal legislation that's about to be finalized into rule within the next month or so, and will be impacting their payment in 2019 based on their performance in January 2017, right, just a few months away. So if practices aren't aware of this yet, they're somewhere living under a rock, but we need to be able to help them get ready and not just scare them with this, right, but to really use those changes in the environment to help support the sense of urgency. I think also certainly recognizing the frustration with the status quo, right? Show me the business case for the status quo. What's really working here? We know there's a lot of frustration from clinicians, practice teams, and patients alike, as well as the payers, the real payers who are, to a large extent, both employers and ourselves as taxpayers, right? Paying for very expensive healthcare. So there are a lot of reasons to change our systems. It's not like we've got a great system right now that everybody's perfectly happy with. And then particularly, thinking how quality improvement can be a great opportunity to build professionalism, which we know that appeals to professionalism and ways to engage providers in professionalism is one great strategy to help prevent burnout and to really help keep folks engaged. Along the way in this discussion, I'm going to point to some great tools and resources that we've identified in our improvement efforts here in the NNEPTN, and call out some of the great tools put forward by some of our other SAN partners as well. So these are live links. When you access this PowerPoint, you'll be able to click right on them. One of those sets of tools is the AMA Steps Forward platform, I guess, set of tools. If you haven't seen this yet and you're either working in a practice or with a practice, I would strongly recommend that you check this out. It is a phenomenal tool. The American Medical Association hasn't necessarily been known in the past for supporting practice change, but boy, they have put their heart and soul into it with this one, I'll tell you. There are some just great modules. So I've called out, again, as we go along, some tools that are relevant for each aspect of this. So this one, Preparing Your Practice for Change, walks you through some of the concepts, the kinds of things that I've been talking about, and really can be a great tool. They're set up as web-based modules with some text, some video, links to helpful resources. Additionally, AHRQ has a similar module, and then under the Safety Net Medical Home initiative that many of you might be familiar with from a few years ago, they've got one on engaged leadership that I think can be very helpful as well. So next step, form a coalition. Again, maybe not quite the same multi-stakeholder coalition if you're thinking about, trying to increase the tobacco tax in your community, but I would suggest within the practice you need a coalition too, right? There's no such thing as quality improvement run by one person. Right, what's better to fail than when it's Mary's project or Chelsea's project, right? This really has to be an initiative that's owned by the team. So who's on your team? Again, thinking about if you're working with a practice or within a practice, who are the ones that really hold the resources all the way from the top, whether it's board, your president, medical director at your practice, to the operational management who's making decisions about allocation of resources, to the frontline clinicians, the front office staff, right, who often have to implement some of these changes, and certainly, importantly, including patients as well, to move from something that is disorganized or reactive to proactive. So thinking again, either the folks you're working with or if you're leading a practice, the fundamental need to create your vision for this, right? It's not, gosh, we really need the MAs who are rooming the patients to take their shoes off, right, to do a diabetic foot check, and on top of everything else they're doing, right? But it's stepping back and saying, okay, we have identified that diabetes is a big issue in our community and a big issue in the population of patients we serve. We know that X% of people with diabetes go on to develop vascular disease and suffer from the amputation of the lower extremity. Well, what's the way to deal with that? Well, we need to increase our rate of foot checks, or whatever it is, just using a hypothetical example, right? But starting with that big picture. And I think many of us who are in this world, who do this work, we kind of forget that not everybody has the big picture, right? We sort of assume, well, of course you're going to do foot checks, or of course you're going to repeat the blood pressure after you checked it, or whatever issue you're working on, because we know the connection to the big picture, but the people we're working with might not, right? Whether that's the front office staff or the receptionist or the medical assistant or even the other clinician on your team, right? So starting with a big picture and having a systematic way for identifying your priorities, right? There's nothing that gets to people more to have one project, another project, and another project with no real visibility for them on why did you pick that? Why did you pick hypertension control, or we're gonna start working on no-show appointments or improving access to care, right? So having a systematic way to do that and making it visible to the people that you're working with is an essential element of that. And then really trying to link the priorities, the specific quality improvement initiatives to that big picture, and doing it over and over and over, repeatedly explaining, right, that link to the big picture 6 ways, 6 times in different ways, and getting very specific about what we're working on, what are we trying to improve, by when, the old model for improvement, right? How do we know a change is an improvement? So again, just pulling out some specific resources and tools under the AMA Steps Forward. You can see a couple here that I think can be very helpful to that process of identifying priorities. And I think another critical step along the way in there is really identifying the what's in it for me, the WIFM, right? So while again, it might be really important to somebody in the organization that one addresses no-show rates or improving access or clinical measure, there's got to be something in it for the person whom this is impacting, right? So we have got to figure out, first of all, what matters to practices and to whom in practices, recognizing that there are different models of practice ownership. Practices that are owned by hospitals or hospital-based health systems might have different incentives and drivers than those that are independently owned, which in our state is becoming less and less, or then community health centers or FQHCs that have a community board. We have to recognize that certain payment arrangements, whether they're still fee-for-service, which again, many of ours still are, even as we move towards volume-based payment arrangements, can have a big impact, right? If we're talking to providers about taking more time to do whatever XYZ step in an improvement process, but they know that every week on their chair, they're getting a report of their RVUs, the volume, right? We've got to recognize that and figure, okay, well then how do we make it this doable for them? And then obviously different incentives related to different specialty type as well. And I think that's one of the challenges in our PTN, as I suspect others, that there are very, very different audiences. So really understanding your audience and what's not only going to motivate them, but specifically what's in it for them in terms of this quality improvement. Not that they don't have the bigger picture of improvement or higher levels of motivation as well, but when it comes down to the nitty-gritty change on the ground, really figuring out how is this going to make their life better, their day better, their payment systems better, whatever that is. In terms of communication, I mentioned we really have to do this over and over. So really thinking concretely, how are we going to communicate the vision and the plan? Again, identifying, understanding the audience, and identifying specific methods, right? Just announcing it in a meeting is clearly not enough. How can we get it into a presentation, whether that's to the staff, to the providers, maybe to the board of the organization? How can we get it repeatedly in front of folks through things like newsletters, posters, traditional or social media, and just remembering the 6 ways, 6 times, right? Once is not enough. Just because this is our job and we're doing it does not mean that they are remembering the importance of whatever task we're asking them to do, or again, that link to the big picture. So it really brings us to the next idea, which is how do we get this work done? So empowering others to act in Kotter's framework, step number 5. So translating this again to the practice team, really thinking about how do we identify clear roles on the team to get this work done, right? This can't be one person's job to do quality improvement in the practice. Oftentimes we found in our work, again, in the primary care side, that people are eager to take on improvement roles, but they need to have that role identified, delegated to them, recognized for it, and clarifying what is their role. In many practices I've worked with, there is the designation of a practice medical director, but there's no description of what that role means, right, or what their responsibilities are. There may or may not be clear designation of a quality improvement manager or director, or even I found in some practices that the title quality improvement champion. So really thinking about how are those roles identified, how do you use everybody up to the highest level of their capacity again, whether it's a medical assistant who might be able to have a role managing a registry, right, a population health registry, or periodically reviewing for quality improvement results, or managing the data wall in a practice, and really getting a lot of satisfaction from that designation and from that role. But just assuming that somebody's going to do it right, or just that one person is going to do it, is not going to work. Again, some great resources here in terms of building teams, creating a team culture, the notion of building teamwork in the practice, not only to have a better operating practice, but specifically issues around a quality improvement approach. Another resource, new resources that I'm citing here, one is the Primary Care Team Guide, which is the work of the McCall Institute, led by Ed Wagner a few years ago, that looked at 30 high-performing teams around the country. And much like the AMA Steps Forward, had some great web-based resources with modules that are fairly short, succinct, really can work well for the practices that you're working with as well. And then I think many of you are familiar with Team Steps, you know, a model that came out of the airline industry and then the Department of Defense. And AHRQ has picked this up and developed Team Steps trainings for ambulatory practices as well. So I would encourage you in the practices that you're working with to think about using some of those tools. Additionally, in terms of this notion of assigned roles, and I mentioned a few slides ago the notion of leadership for change. So really thinking about the importance of defined leadership roles in the practice, be they at the organization or at the practice level, and again, not making the assumption that people are born leaders, right? So I mentioned the good fortune that you might have in working with some practices that have a highly developed practice administrator and a clinician leader, that important dyad. You're lucky when you find that, right? So who are the folks that have those roles in the practice, and what are their leadership skills, and what can be done to really help develop those? You know, I like to say I must have missed the class in medical school about being an effective leader. It really was not taught in my era. I'm not sure now. It may be more embedded into a medical school curriculum, but we can't just assume that clinical leaders, whether they're the practice manager, the nurse manager, the QI manager, or the medical director, right, necessarily has those skills, and really need to think about, well, what do we need? We need people who can understand the task, who can really use data effectively to help provide feedback, let data speak the truth and point the way, right, and who really have that level 5 leadership described by Jim Collins in his writings about leadership, that really have that resolve combined with humility, and understand that they're trying to work on something that, I love this line, that are dedicated, where they're dedicated to a future they may not inhabit, right? So that they're committed to making changes in the practice that are going to support the big picture. And that, again, is just not always something we find. So having the ability in your work with practices to either find those people, or if they're in a role and maybe don't have some of these skills, the ability to name the vision, to the power, right, to legitimize the change, to be able to both, this one might be a sensitive one, public and private roles, given the last debate discussion, but we'll stay away from that. But to really be able to meet privately with individuals and support the change, right? You can't have a medical director who says, in one meeting, okay, we're going to adopt this EMR, and then in the meeting with providers, gosh, I hate this EMR, how we can ever do that, right? So we're going to find that, and how do we work with those folks? How do we really help either identify that maybe their role isn't clear, maybe they're not the right person for the role, and or find ways to mentor them and work within the practice to try to cultivate those leadership skills, because without that leadership, getting a practice to successfully adopt a culture of quality improvement is darn right difficult, if not impossible. We've got some tools cited here again in terms of leadership skills, leading change, and then through our own NNEPTN and our online learning lab, our online learning management system, we're working with an organization here in Maine called the Hanley Center for Health Leadership that has a lot of experience with leadership development, and we're going to be offering soon some modules specifically on leadership development for clinicians and practice teams that will be available to our practices and certainly others in the TCPI as well. So if we keep going here along the framework of the 8 steps, so we talked about identifying effective leaders and then planning for and creating short-term wins. So what priorities, right? Instead of tackling the biggest, most difficult problem in the practice, what can we identify and work with the practice to identify as things that are both important, urgent, and achievable, really trying to create short-term wins to give them confidence that they can do this work while collecting and sharing data to track the improvement, showing them, right, that what the change is, how we know it's a change, and how we know it's an improvement, the model for improvement, and really trying to be very explicit about a specific quality improvement approach and methods. You can see some of the ones, the sort of classic ones listed here: PDSA cycles, process improvement methodology, Lean, doing workflow process mapping, Six Sigma, total quality management. There are different tools that can be helpful in different situations. We actually are going to be coming back to you through the NRHI learning community in December. I think it's December 22nd, when Jessica Reed, who's here with me, is going to be leading a discussion about more specifics on these different quality improvement methods. And I think to many times it doesn't necessarily matter which one, but having a methodology is critical, and following that in order to be able to have a structure for this improvement and to be able to identify a system for collecting data that can then be used for feedback. So thinking for a minute about some of the key ideas in terms of collecting data and then being able to use data transparently within the practice. Some key ideas. Leadership has to commitment to and confidence in using data to drive improvement, right? We're in clinical settings, we're working with clinicians who are at their core scientists. We've got to be able to find and use data and then share it in a transparent way and in a way that feels relevant to the clinicians and the clinical teams. I think we're going to hear a little bit more from Jessica and or Chelsea in a few minutes about examples of sharing data that's shared openly at least the practice level, and ideally by provider. I think within practice, there's nothing more motivating to providers than feeling like they have opportunities to improve, right? Nobody went to medical school to be last in the performance ranking. So looking for opportunities to do that in a safe way, a way where there's an environment where there's trust in the practice, and then a real commitment to celebrate successes and really use that data to drive improvement, not to shame people, right, but to be able to look at best practices, bright spots, and to drive that sharing of ideas. Again, thinking of the different QI methodologies, whether it's PDSA, Lean, etc. We'll talk more about that in another couple of months, but they share some similarities in terms of an organizational commitment to quality, focus on the customer. This one, very importantly, a focus on systems, not people, right? A common theme in effective quality improvement strategies, that this is not about individuals and errors, but really about systems that need to be redesigned to work better, and that work best when using a team-based approach that is data-driven and committed to this culture of continuous quality improvement. A few resources listed here in terms of, again, some of these specific quality improvement methods, again, can be great tools, whether you're training your own practice facilitators or working with staff to build that quality improvement capacity. within the practice team. And then the last two steps on the Kotter framework, trying to consolidate the changes and institutionalize changes. So moving from the small test of change, right, to really saying, how do we build this into the system moving forward so that we make sure we have ongoing systems for timely feedback and reporting, showing what is an improvement, having some system for data dashboards, I mentioned a data wall, and continually trying to reassess what's working, as well as what's working within the practice team culture, thinking about the use of surveys of staff, of patients, to get that feedback and really have a better sense of how things are going among the practice team as well.